So again, welcome everyone. It's going to be recorded, so I hope you're okay with that. And let me introduce Nicole. Nicole works it's from UCLA, so University of California at Los Angeles, but she's based in Kinshasa. Hi, Nicole, and welcome. And she will be presenting. So introduce yourself with maybe a little more and go on. Thanks.
Awesome. Thanks so much, Carolina, for hosting this presentation. I really appreciate it. So I am Nicole Hoff. I am an assistant adjunct professor at the University of California, and I've been based in DRC, the Democratic Republic of Congo, since 2011, where we have close collaborations with the National Institute of Biomedical Research and the Kinshasa School of Public Health. And so today, Carolina invited me to present. I think we need to. It says host disabled screen sharing.
1 second, I'll enable it now.
Awesome, thank you. And so today I'm going to present on kind of a history of our work in DRC. And certainly what I'm going to present today are not the only DBS serosurveys that have been done, but I'm really going to focus in on our work that's been done with vaccine preventable diseases. And so I certainly know that there's been a number of studies that have been done looking at HIV using dried blood spots and malaria studies as well. Okay, so I can
just
share.
While you share DBS,
Yes.
Is dry blood spot for people that may not remember that acronym. Thank you.
Okay, and I'm actually going to turn my camera off just to make sure we have good enough internet. Okay. So as I mentioned today, I'm going to present on our vaccine preventable disease serosurveys using dried blood spot samples in DRC. And this is kind of a long history from 2013 to 2021. As I mentioned, we work with a number of collaborators. Most specifically, this work has been done with the Kinshasa School of Public Health and the National Institute of Biomedical Research. But then certainly we've worked closely with the EPI, Minister of Health. And most all of this work has actually been funded by the Bill and Melinda Gates Foundation. And then we've had a number of close laboratory partners as well, which I'll discuss a little bit later throughout the presentation. So I'm just going to give a little bit of overview of what dried blood spots are, talk about them and their use in serosurveys and why this has become really an important question. I'm also going to run through some examples of how we've looked at vaccine preventable diseases using dried blood spots in a few different studies. And some of the results that we've gotten for that. And then just to finish this presentation is just to say what we have available in DRC. So not only looking at the testing capabilities that exist, but as well as some of the samples that are already available for testing and some conclusions. And then hopefully at the end, we'll have time for some question and answers. So dried blood spots are a form of blood sampling where whole blood samples are collected on dried paper. And so this really provides a logistical and safe alternative to liquid samples, especially working in conditions where you have uncertain electricity, really far distances to travel, and a number of other logistical constraints. So what we do for these samples is they're collected through a finger prick, and then 5 spots are dropped on the card and then left to dry. We can actually then take these samples and elute the sample to basically be able to do ELISA, DNA amplification, Luminex, which are multiplex assays, so they'll test for multiple antigens, and then microneutralizing assays. So they're really like an interesting type of sample for collection that allows you to do still almost as much testing as you would be able to do with a serum sample without necessarily needing all of the constraints of having a serum sample. So just to give some ideas, these are basically what ideal samples look like. We want them to be completely saturated with the blood, but not necessarily oversaturated, because what we'll actually do is take punches. And so on this bottom card, you can actually see some of the punches that are taken from the samples. And a lot of the assays that have been developed and that we've been using use a really tiny amount of sample. So within these 5 punches, you may have enough to do 2 or 3 different assays, if not more assays. However, every once in a while, we will get a number of blood samples that are not necessarily valid. So the first example would be if somebody like continues to touch their finger on the card, or like they're getting really small spots. So these samples will not necessarily be valid or be able to elude to get them sampled to test. The bottom one is samples that are maybe too small. And then every once in a while, you'll end up with a prick that has more blood than you were expecting, which then leads to these blurred lines that are in these other two figures. So some of the main advantages that we've seen using dried blood spots are the simplicity in the field. We're able to hire interviewers that can both collect the questionnaire data and samples at the same time. And so this has been a really important consideration because when collecting whole blood or serum samples, we typically have had to hire additionally like phlebotomists and interviewers, along with having mobile lab teams. So using DBS has really reduced this to just being able to rely on individual team members who are trained on both portions, the questionnaire and sample collection at the same time. It also has a reduced risk of harm to participants. So reduction of infection, reduction of pain, and also time. We find that with the DBS collection, this typically adds about 2 to 3 minutes at the end of a survey for collection compared to when you have to do intravenous blood draws, which can take 10 to 15 minutes of additional time. Because of the amount of the materials that's needed, it also has turned out to be less expensive and so has become a very cost-effective solution for being able to collect samples and being able to add on these types of serosurveys to already established surveys. And so I'll kind of talk a little bit more about that later. And then because of the sample type, cold chain is not necessary for sample storage. However, once the samples are being stored for longer term, we tend to store the samples at either a -20 or -80 for extra long-term storage, just to make sure that their integrity stays as high as possible. And another advantage that we found of DBS has been the ability to ship these samples without necessarily needing huge logistical efforts. Once they're packaged, they can actually be shipped in luggage and checked, and they can be prepared, they can be preserved for long periods of time. So we've seen studies that have looked out 5-6 years after sample collection with limited deterioration of the serologic responses. However, yeah, I list that with a caveat that this is if they're kept in proper conditions. So I'll continue on that. One of the things that we end up using is that once they're packaged, we make sure that they have desiccants and humidity indicator strips to make sure that the samples are kept in the best quality possible. So this kind of requires an additional stage of ensuring that before the samples are packaged, they're dried fully, which has been an interesting thing to try and overcome in some of these places that are really humid. However, we have done a number of things that have not only protected the samples, but let them dry in adequate conditions without having any degradation or mold or mildew that have grown on them. We've also found that using the lancet, certain types of lancets have also been important considerations. If we use too small of lancets, the finger prick might be too small, and so this might be difficult to draw 5 full drops from children. But we also don't want to use lancets that are too large or other types of things that might create a larger site of injection. Also, we found that the placement of finger and the lancet also have an impact of how much blood you may be able to get and collecting a sufficient sample. So these are mostly considerations that we take into account when we're training interviewers to be able to collect these samples. However, you'll see in some of the studies that we've done, these are not necessarily the first DBS studies that have been done. So a lot of interviewers have actually been really well trained on how to adequately collect dried blood spot samples. So for example, one of the assays that we've worked with, one of the teams that we've worked with has been the CDC polio team. For their assay, they need 3 6-millimeter punches. So 6 3-millimeter punches is basically one entire circle. So if you look on these cards and you see circles that aren't entirely filled in, this may require the person doing the test to pull samples from additional spots just to make sure that they have an adequate amount. So this is kind of a brief overview of how we've done our typical sample collection. Almost all of our studies have started off as some type of a coverage survey where we've been able to nest the serosurvey within that survey. So all of the samples that we collect will also have all of the additional survey information. So we'll typically have the study protocol, site maps, which I'll show a little bit later on, informed consent documents, enrollment forms, just to be able to track everything that's been done and ensure that all administrative processes were completed. And then additionally, when we're collecting dried spots, we'll also have a document that goes to the laboratory to help ensure that the laboratory is tracking all of the samples and that we're checking what kind of quality and ensuring that they've been correctly categorized. And then typically in our DBS collection kit, we'll include one 21 gauge, 1.8 millimeter retractable lancet, one Wattmit 903 protein saver card. There's other types of cards that have been developed, including ones that have individual punches already prepared. However, for our field work, we found that these have been worked really well for our interviewers, and also a bit made it so that we have kind of larger circles for when the blood is collected. We also include an alcohol pad, a gauze pad, a Band-Aid, and then barcodes for ensuring that everything is correctly labeled. We've typically done our questionnaire in an Excel format with conversion to XML for tablet use. So most recently we've used GeoODK, but we've also used Survey CTO and just ODK Collect. However, really any format that allows for survey data to be collected offline has really been what we focused on. So for most of our surveys, we've typically asked household questionnaire and then included every child that lived in the structure and was available at the time of the study between 6 and 23 months. When looking at the actual vaccine coverage data, we typically limit this to 12 to 23 months just to ensure that we're looking at complete vaccination coverage. But depending on the purpose of the survey, we've had additional questions, including thinking about zero-dose children, which we think are particularly useful in collecting the information from those under 12 months of age, just because it's a more recent history. During the surveys, we typically ask about family demographics, health services, routine vaccination, campaign vaccination, and then knowledge, attitudes, and practices. In order to try and limit how much time we're taking up from families, we really try to limit the surveys to 30 to 45 minutes. And this is just kind of a general overview. So every study that we've done has had slightly different questions or different focuses, and kind of different time constraints that we've wanted to make sure that we respect. So this is just an overview of the typical ODK questionnaire that we use that starts off in an Excel format. We'll typically include as many different languages as possible to ensure that we have covered any local language that might be included. So just to give some background on the public health implications for serosurveys with linked biomarker data. So vaccine coverage surveys have been used for a long time to estimate population that received vaccine doses. And so surveys serve a slightly different purpose in that they're estimating the population immunity that can also be impacted by numerous factors, not just those that are collected during the vaccine coverage survey. So the coverage surveys might be able to discern between routine and supplemental immunization activities and identify missed vaccination opportunities, but they can also suffer from significant recall bias, especially when you're working in a place like DRC, where we may have lots of a high percentage of the population who doesn't necessarily have a vaccination card. Whereas serosurveys can provide objective biological markers. So this can help us better understand some of the disease risk. However, we've found that a lot of the times, because of the nature of the serological testing and that it's looking for an antibody response, we're unable to discern between natural infection and vaccination response. So this is one consideration that we've really taken into account of what our limitations are with the data that we receive. So when those surveys are representative of population, both they monitor immunization program performance, especially if they've been repeated at regular intervals, and they can also provide complementary information. So one of the things that we would aim to see is that for certain markers, especially tetanus, diphtheria, that the serological response would be almost similar to that of what we see in the reported response. Because of how antibodies form. Measles has a bit of more interesting history because We won't necessarily be able to discern between circulating measles and having natural infection versus the antibodies that could be generated from being vaccinated. In most of the assays that have been developed, these look almost exactly the same. One of the things that we've also found interesting using serology has been the inclusion of rubella, for example. So in the DRC, they've not yet introduced the rubella vaccination. And so we've tended to include rubella as kind of a proxy for understanding what the background rate of rubella infection is, just for when rubella vaccine is eventually introduced, that we would be able to already have an idea of what background rates we can expect. And this can be especially important for rubella, which also has the implication for pregnant women and congenital rubella syndrome. So the DRC has actually had a number of successful coverage surveys, and they've typically included sample collection, either serum or dried blood spots, for linked biomarker results. And this has really been done with almost limited or no impact to the original data collection plan. So we've really aimed to try and make these nested serosurveys really just that, nested, in that they can be easily implemented and don't add a significant amount of time to the data collection portion. So these are just some of the examples of vaccination cards that we've seen in the field, which really call into question the quality of data that's being collected even through the vaccination card. So the first example is a card where basically you can tell that all of the dates, both when they were supposed to be vaccinated and when they were vaccinated, were likely filled out at the same time. The second card is an older vaccination card, so it's missing some of the vaccines that would have been given despite the child being old enough. So for example, I think IPV is missing from this. However, this child would have been eligible and alive during the time that they were giving IPV vaccination. And then this third one is a handwritten card. So at least they have a written documentation. However, we're not sure of exactly how it was completed or any other information. This is just some more examples of additional vaccination cards that we saw when we were in the field. And so really I think these pictures were taken in 2016. I'm looking at the dates, 2016. However, looking at the more recent studies that have been done in 2020 and 2021 through the Kinshasa School of Public Health coverage surveys, they've also taken pictures of vaccination cards, and we've continued to see a lack of consistency of vaccination cards throughout the country. So getting into some examples of how we've used serology in collaboration with coverage surveys or other types of large-scale surveys. So the first time we actually implemented a VPD coverage survey including serology was during the 2013-2014 Demographic and Health Survey. So the Demographic and Health Survey collects women at a nationally representative, it's a multi-cluster, multi-stage stratified cluster survey using administrative data. And so for the 2013 design, they had 536 clusters, which included over 18,000 women and almost 9,000 men. So dried blood spot collection is not necessarily a new methodology for the DHS. Historically, dried blood spots had been collected from a certain portion of men and women in the study to be tested for HIV prevalence. And in addition, our collaborators and colleagues at UNC have used dried blood spots for a number of years to look at malaria prevalence and some of the genetic differences within malaria as well. So adding on the vaccine preventable disease work for children really was just one additional piece for the Demographic and Health Survey. So through this survey, we were able to collect dried blood spots from almost 10,000 children, 6 to 59 months, that were in eligible households. So this just gives kind of a general overview of how the households were selected. So there was 19,000 households, and then anyone that was selected for the questionnaire for the men was also selected for biological samples from children. And then in addition, they collected biological samples from women and men as well. So the first portion of these samples were actually tested for HIV. And then they were tested for malaria. And then if there was anything left in this sample, we actually had access to those last samples to be tested for vaccine preventable diseases. Half of the samples were tested for polio neutralizing antibodies, and then half of the samples were tested for other vaccine preventable diseases. So during this first study, we actually used a multiplex assay from Dynex that has a similar kind of background to the Luminex assay, which is another multiplex assay. So one of the things that we really wanted to think about when thinking about the serosurveys was how to profit from using multiplex instruments. So standard ELISAs will only look for one antigen. So if you're trying to do multiple antigens, it would require needing multiple assays. And so this can also be cost prohibitive. Whereas using multiplex assays, we're able to look for a number of antigens using the same sample and one single plate. So these really present cost-effective strategies. However, as we came to learn, there's a lot of work that goes into the validation of these assays to ensure that they're providing really high quality results that would be comparable to if you were using certain gold standards like neutralization assays. So the first assay that we ran for the 2013-2014 DHS was a measles, mumps, rubella, tetanus, and varicella assay. So as you can see, this assay had a strategy where there was spots within the well. So each of these would be an individual well on a 96 well plate that would look for the specific antigen. So this is just an example of what the readouts look like. So each well within the larger well would give a readout to say if that was a positive or a negative sample. So assay response for each assay was calculated as the log of ratio to positive control. So in addition, there's positive and negative controls on every plate. So just I'm really not going to go much into depth on all of our different results. But looking at, for example, measles, we really didn't focus on the vaccine coverage for measles, knowing that one of the limitations for measles specifically was that we wouldn't be able to necessarily tell the difference between children who had previously had measles or vaccinated against measles. However, we thought that this type of assay could be really useful in helping to understand the immunity gaps. Where do we see negative children? So from the 2013-2014 DHS, between children 12 to 23 months, we found that 26.6% of the children who reported their status as being vaccinated were seronegative for measles response, and that 36% of unvaccinated children were seroreactive. So within this 36%, surely a number of those would also make up a number of the children who would have been infected. So we also saw significant differences in seroreactivity rates between children who had vaccination cards and recall bias based on a mother's recall. So for the DHS, all information for the children was only based on maternal recall. We also were able to look at polio neutralizing antibodies, so looking at type 1, 2, and 3 using dried blood spots. So these assays were run at CDC using a polio microneutralization assay. So generally, they were able to elute the serum from 3 punches. They typically would test 384 sample or well plates with 14 samples per plate. And this was because not only were the samples tested in triplicate, but they were also tested in 2-fold serial dilutions. And so they were able to only test about 765 samples a week. So this has been one limitation with collecting a lot of the samples, has been thinking through what kind of assays and what kind of methodologies could produce high throughput results to make sure that results are coming out as quickly as possible. So from that work, the population immunity to poliovirus for 2013-14, we were able to break this down by not only the province, but also by the polio type. Type 2 had the highest rates across the board for almost every province. Type 3 had the lowest, and I think these are pretty standard results for polio. And so this was in 2013-14. You'll come to see later on how we look at more specific provinces. So, and while the overall immunity was high, we were able to see different pockets of low immunity throughout the country. So how we can use some of these results, especially with the serology, to really help base operational plans to better vaccinate and have higher coverage in some of these areas. The second time that we had a serosurvey was with a targeted serosurvey in Otlumami province. So this province was selected because we wanted to quantify the protection against poliovirus in health zones that it had a history of vaccine-derived polio outbreaks. So I'm sure many of you know currently this area as well as been the most recent site for the current large outbreak of vaccine-derived poliovirus for 2021 or 2022. In addition, we've started seeing vaccine-derived polio type 1 cases and not just type 2. However, in 2017, this area also had vaccine-derived polio type 1 cases as well. We also wanted to evaluate the baseline seroprotection against polio type 2 after the cessation of OPV trivalent. So the specific timing of this survey was in July 2016, which we thought was sufficient time after the switch in April of 2016 from OPV trivalent to bivalent. And also IPV had been introduced in the country starting in 2015. This typical sampling frame that we used for this study was to use a similar frame that the DHS had used. However, instead of working off of the administrative data, we were working off of microplans from health zones. And so we had a general sampling methodology that had a number of sites selected in 7 out of 8 health zones in this area. And we were able to enumerate households with the help of community mobilizers, the nurses, and the village chiefs. And then we designated a skip pattern for the houses. We also included all children 6 to 50 months who lived habitually in the house and were present at the time of study. And then one of the things that we did change that wasn't necessarily included in the DHS was that we included parents and guardians, not just the biological mother. So this helped to kind of open up the number of children who were included and ensure that we had some better representation, especially for children if their mother was not physically available in the house at the time of the survey or wasn't the primary caregiver. So again, we were able to test these samples for the measles, mumps, rubella, tetanus, and chickenpox. And then a portion of the sample actually also went to CDC, where they were able to look at population immunity to polio using the neutralizing assay. So we saw somewhat high results for type 1 or type 2 and type 1, with type 3 lower. However, these results were slightly lower than what we saw in the province for 2013 and 14. So the last survey that we did was between 2018 and 2019. It was a rapid serosurvey in Otlumami and Tanganyika province. So the original feedback or original objectives for the 2018 portion of the collection was to really see if we could deploy a rapid serosurvey in a VDPV outbreak area to provide timely feedback. And then also to prepare, to determine and compare post-campaign polio vaccine coverage. So one of the things that we did in 2018 was focusing on sites that had multiple vaccination surveys versus multiple vaccination mass campaigns versus control sites that had no VDPVs and no campaigns to compare the prevalence of polio antibodies. We also wanted to determine if vaccination activities were adequate to interpret the circulation of CVDPVs in an outbreak area. And then we wanted to also provide just general information on routine immunization, healthcare accessibility, and the utilization based on qualitative and quantitative research, and have a geographical context of this study. So in 2018, we were able to sample from 8 health zones. And then in 2019, we went back and we completed every other health zone in the 2 provinces that were not collected in 2018. And so we actually worked closely with a number of different partners for this, working with others at UCLA, the McKing consultants with the Gates Foundation. And then in 2019, we really implicated Grid3, CSUN, FlowMinder, and WorldPop team to help us do some of different sampling strategies for selecting sites. So this is just an overview of the VDPVs that have been classified in Otlumami and Tanganyika in 2017 and 18, and also just to give a little bit of geographical context of these two provinces. So Otlumami is made up of 16 health zones, and Tanganyika is made up of 11 health zones. In the larger picture where you see the red dots are health zones that had experienced VDPV cases. And so Nkoro, Tanganyika, and Tanganyika, Manono, and Tanganyika, and then in Otlumami, Luamba, Mukanga, Melonbukulu, and Butumba. And as you can see, there was also the one AVDPV1 that was in Nkoro province in 2017. So one of the things that we did for this survey was we changed the sampling frame. So from the 2013-14 DHS, they had used administrative boundaries to do their site selection, and so that was reliant on administrative data. However, the vaccination program in DRC is based on a health zone structure, so it made it difficult to make direct comparisons to health zones when using administrative data. Also, the DHS had only collected information on children whose biological mother was present to provide information. In addition, in 2016, we used the API microplans from each health zone. However, we found that these had a varying degree of completeness between health zones. So not every microplan was made the same. So we ended up finding that some of the microplans for the vaccine distribution, and when they were broken down by the health area, might have only one village listed. Whereas we found that other microplans would have every single village listed. So it made it difficult to have just a selection based on a village. So instead, we worked really closely with the Grid3 group and others on our team to use settlement extraction files, which indicated where populations lived using satellite imagery. And so some of this work stemmed back to when we worked on microcensus work in 2016 and 17. And so our idea was to use these settlement extraction plans to do site selection so that the site selection actually happened at a higher level. So this is just an overview of sites. So this methodology, I mean, every site selection methodology or sampling frame that you can have will always have limitations. We wanted to ensure that we sampled from individual aire de santés and didn't have duplicate aire de santés. So this sometimes required having backup sites. And there still was some field validation. At the time of this study, in fact, when we drew the sites to be selected, almost 20% of our sites selected were not named villages. So we actually had to develop methods to send teams to these villages. So just an idea of how this methodology works. So if the first step one would be to look at your settlement extraction file. Step two, they aggregated the settlement areas into a single block. And this was to ensure that if you were dropping random GPS points, that they wouldn't end up in a place that had no households. We also excluded from these sampling blocks settlement extractions that were under a certain size. So if they didn't have enough buildings in them, certain things like that, or they were just scattered individual houses, these may have been excluded from the sampling frame. We then dropped a number of points within those blocks, but we wanted to make sure that they were within a certain spatial distance to try and ensure that we were looking in different aire de santés. And then step 4 and 5 were basically to disaggregate those blocks and then say what the names of the villages. So there's a number of steps that go into this. But overall, at the end, we were able to put together maps to help the teams navigate to each of these areas. So we would try to include as much information as possible on the name of the village, roads, other methodologies for getting there. And once these were developed, these were actually completed ahead of the survey. So when we were in the field, one of the portions of our training was to actually work with the health zone staff to really identify these villages and ensure that there was villages in these areas. We definitely had 1 or 2 cases of this 40 to 50 villages that were selected, where the village selected was no longer in existence. So this method definitely had a number of places that had to be validated in the field, but it took really a lot of the site selection process out of the interviewer's hands and made it fairly random. We also drew circles of boundaries around each of the GPS points. So we would ask our teams to start at this GPS point after doing the civilities of meeting village chiefs, and then they would collect household samples within the defined area. And so at the end, what we were actually able to see, because GPS points were collected from every house, was we could actually see all of the households that were surveyed and have an idea of where interviewers had gone. So this also provided a little bit of additional layers of understanding how enquêteurs were selecting houses and other information. So I don't think either of these show, but we also tried collecting information on refusals, or if interviewers had visited the houses and were unable to complete surveys. Overall, at the end of this survey, we almost hit our target size for Otlomami. The main reason for this was that in Baka, it was a really tiny health zone, and so they don't have nearly as large of a population, and we were unable to select as many clusters as we needed to survey. And in Tanganyika, we didn't have any issues with meeting the sample size criterias. One of the other things that we've really had a lot of work in has been local involvement. So really having community mobilization, sensitization, logistical assistance, and just in general local presence was a really important component to all of these surveys. As much as possible, we've recruited local interviewers, and slowly the pool of interviewers is getting larger. So a lot of them have had previous trainings in other household surveys, and then local knowledge based in the health system. And then after we were done with surveys, we were able to discuss preliminary findings. And so in fact, we worked really closely with a lot of our interviewers during training. And so in one instance, we went to a village during the 2018 survey, and we actually found a village where almost no children had been vaccinated at all, despite the fact that they were only about 7 kilometers from the main health zone office. So to us, this also presented certain opportunities that while these weren't official data, that we did bring this to the attention of the health zone staff to say that this was a really concerning trend, that these children were only 7 kilometers away, yet we were unable to find any child who was completely vaccinated. So I think having these kind of smaller serosurveys can also present opportunities really to have a direct impact at the time of the survey as well. So I'm just going to run through some results. There's so many results that have come out of these studies, much too much to cover in this time period. But for example, in 2018, we were really interested in some of the information from routine versus vaccination campaigns. So in that portion of the study, there was 982 children. We saw that 697 reported that they had received some form of vaccination campaigns. We saw that 285 had reported no vaccination campaigns, but we see that they were targeted in vaccination campaigns. One of the interesting findings from this first part of the survey was that for type 1 and 3 polio vaccination, neutralizing antibody response, we saw that all 3 of our strata that we selected had almost the same exact response for type 1 and 3. And these would be the ones that you would mostly see within routine vaccination. For type 2, we did see a lot of differences. So in the first 2 strata that are listed, we saw almost the same type 2 vaccination coverage. And then in the 3rd strata, which was our control strata, which had no supplementary immunization activities, we saw a much lower type 2 response. But one of the things that we thought was interesting was that in the second category, Most of these children had reported having 4 to 5 supplementary immunization activities. And in the first column, most of these children reported only having 1 to 2 supplementary immunization activities. So, and this we've seen in a few of our different surveys, that in places that have had multiple campaigns, we don't necessarily see that you're seeing a huge increase in the polio serology, indicating that really, if you're not reached by the first or second campaign, you likely won't be reached by the 3rd, 4th, 5th, or 6th campaign. And then when we look at the results across the board, between 2013-14, the follow-up in 2016, and then the most recent in 2019 that we have results for, we are starting to see the polio coverage drop over time. And it's true, these are not directly comparable. So we're not trying to say like these exact populations, but looking at the general trends, these are some of the estimations that we've made. The other thing that we did is we've worked with CDC really closely for a really long time. So to explain the Luminex assay, which is another multiplex assay, we've worked closely with them, and they've developed an assay that uses Luminex, which is a bead-based assay. So the multiplex bead assay, MBA, is what they've called it. And so basically what they're using is tagged beads that they then pair with the antigen to detect different things. The interesting thing is that each bead will have a marker on it, indicates that it could be used for a different antigen. So for example, we've been working with them on a VPD specific panel where they're able to test for measles, rubella, tetanus, and diphtheria. And so we've recently got some of the results back from the 2018 and 2019 dried blood spots. And so these are really preliminary, just comparing what we see in the coverage for different antigens versus the seroprevalence. The one that sticks out to us is, for example, in Tanganyika, we see that the vaccination coverage was slightly over 50%, which was reported vaccination. The seroprevalence was just slightly over 30%, so a 19% difference. Whereas in Olomami, we saw almost the same prevalence between the vaccine coverage and the seroprevalence. And then between tetanus and diphtheria for both of the provinces, we saw similar decreases between the reported coverage and the seroprevalence. So this is work that's being ongoing right now with CDC Atlanta. So what's available in DRC? So right now, the current testing capacity is that right now polio sample testing is only available at CDC Atlanta and other selected labs. So this has led to a really long wait time for being able to get results because these samples go into a queue. However, these samples usually fall behind more urgent testing needs. So the outbreak in the US, for example, of VPDs earlier this year, a lot of the clinical trials for NOPV have gone before these studies. However, this testing method is able to use dried blood spots or serum samples. And we've really been focusing on how we can get other VPDs to be tested in country. So using the multiplex panels with Luminex, so measles, rubella, tetanus, and diphtheria. So this is a validated assay that's at CDC Atlanta. So currently, some of these samples for 2020 are in Atlanta waiting to be tested, and we have the other portion here in Kinshasa. So we've been working closely with them to have a validation panel to try to move to in-country testing. But actually, this panel is part of a much larger panel that they have been working on that also includes malaria antigens and other neglected tropical diseases. So really focusing in on how we can build in-country capacity for routine serologic testing. This would really increase the feasibility for conducting and monitoring of the routine immunization strengthening program and then other vaccination activities. So this would help by reducing wait time for results and then an eventual push for technology similar to for polio. So how we can continue to make sure that as much testing as possible is done in country. And we do have a lot of samples that are currently waiting to be tested. So there's the 2018 and 19 samples. We have gotten information back for part of these samples for polio, and then for those samples for some of the VPDs. We also partnered with the Kinshasa School of Public Health in 2020 and 2021 to collect dried blood spot samples from 2 provinces in 2020, so Olomami and Tanganyika, and then in 2021, 3 provinces, so Olomami, Tanganyika, and Lualaba. So these samples are awaiting testing, and we've been really working hard to see how we can ensure that the platform is in DRC to do this testing. So in collection, we've found that DBS collection is feasible in DRC. I focused today on vaccine preventable diseases. However, as I mentioned, there's been a number of other studies that have been done. Looking at the cold chain requirement not being necessary, this has made this ability to have fields in the team collect the samples with somewhat less oversight than is required when you're collecting serum samples. And also the shipment of samples in general is much easier. We've also had a lot of great experience with serological assays that are capacity in country to test. And this information really provides us with additional evidence to support vaccine coverage estimates. So this has been especially important in the absence of written documentation. There have been a number of things that have looking at recall versus actual vaccination. And then there has been some differences. And so I think having these continued studies where we're able to kind of monitor how serology or serologic responses are changing really add to evidence that we may not have available to us, especially if we're wanting to monitor for long-term changes. And this really builds capacity in country. And we found that nested biomarker surveys can be add-ons to larger studies. And this really reduces the cost of sample collection, especially for the DBS, which really only add a few minutes to each survey. So mostly we also have a lot of partners to say thank you to, including those who have helped us collect these samples, test these samples in country, out of country. So thank you.
Thank you so much, Nicole. This is a lot. I think
shoving 10 years into 10 minutes.
Oh, that's awesome. I think there's so much potential. I put in the chat several papers that that I find of interest because, for example, in Ethiopia, there is some experience using the tetanus serology, particularly for monitoring the implementation of the Reach Every District quality improvement strategy, which has some similarities, let's say, to what other countries are doing in terms of really strengthening program, starting from the bottom up. I also put a bit too long, the last part in the chat, I put one of the SAGE recommendations from 2019, and I think we have a few people who were members of the SAGE data working group for that provided recommendations in 2019. The last one saying further work on defining the role of serosurveys for immunization program management at different levels across different diseases and different epidemiological contexts. So this is very timely, and I just want to tell everyone that we are looking into how we bring serology more into the regular work we do in terms of guidance and surveys. Nicole, if you can go to the Q&A, there are a few questions in the chat, keep them coming, but if you can read and maybe start responding, I would please go ahead and pick the first two together. I think they are very related.
Yeah, so the first two, so I did forget to mention, for the children that are under 12 months, we do use a heel prick. Sorry for this. We do, like, the heel prick is also what we use instead of a finger prick. For the efforts to include polio serotypes, this has been a really big question. I don't think that this has necessarily been tried at this moment. Right now for the polio assay, it's a microneutralization assay. So it uses, I think, live virus in the assay. So in fact, the reason that there's so few labs that do this is because of the specific type of assay that's needed to look at the different serotypes. This is one of the things that we've been discussing a lot with the Gates Foundation on thinking through, are there other types of assays that might also work in the future? I'm not sure if the multiplex bead assays are going to be the way that it will work, but I wish as well that this could happen. The full results. So it depends on which study that you are discussing. So some of the earlier results, especially from 2016, early 2018, and then certainly the DHS have been published. We're currently working on the results from the 2018 and 19 right now. But we've shared all of this information that I shared with you today. We've also shared it with the EPI program in country. And we try to give as many presentations as possible to make sure that this data gets distributed. Also, Jessica, I think this question is actually really interesting and one that we have been asking for a long time. Because one of the things that serology can actually help with is, especially if we have fairly good vaccination card information that we can help triangulate and we still see lower vaccine coverage. I think looking at the cold chain data could be a really interesting thing to include, especially because there have been questions on, is it possible that these vaccines are traveling long distance? We're not having as high monitoring in some of these areas. Is there times that we don't know what temperature the vaccines are being kept at? Could this lead to reduced vaccine efficacy? This isn't something that we've specifically really looked into specifically, but I do agree that it's really an interesting component, especially if you see these areas with large discrepancies. Oh, sorry, I was trying to, so for Laura, I was trying to include as much information as possible to cover what we've done in general. So I did not include results for rubella. Rubella is actually one of the best performing antigens on almost every panel that we've run when comparing it to the WHO standards. So it's actually a really good antigen, but I suppose that it's also fairly good in DRC because all of the results that we're getting are from natural infection since rubella has not been introduced yet into the vaccination calendar. So certainly feel free to reach out to me and I can actually share some of our rubella information as well if you'd like. So one thing that we were talking about, so this is from Marceline, is I think that there's not been enough discussion on the CVDPV1s and that emergence of just in general the VDPV2s in DRC, and especially Olomami, I think should really come into more question of comparing the vaccine coverage results to what we're seeing with I'm trying to think, the vaccine coverage results compared to where we're seeing emergence of VDPVs. And Olomami has posed a really interesting situation because they have some of the highest reported vaccination coverage rates in the country, over 87%, yet we continue in this certain area, kind of in the map that I showed to see here, where we continue to see this emergence of VDPVs. So really looking in this kind of beltway between Kabalo, Imbulula, Kongolo, and Koro, Manono, Luamba, Kinkanja, Kitinge, all of these areas have continued to see VDPV outbreaks as early as well, not as early, but really continual outbreaks since almost 2012. So I think this is a question that would be really great to have the EPI really involved on thinking through some of these things and how we can use the vaccine coverage, the polio serology, the other serology, and then just seeing where the cases are to really try and understand what could be the cause of this.
Thank you, Nicole.
And then the cost implication. So for the DBS collection kits, we typically have the DBS collection kits are about $3 a kit, so $3 per child for the sample collection. Most of this cost is for the DBS card. They're $1.25 per card, I think. And then by using a multiplex assay, it's really able to help cut down on the cost. And especially if you're able to couple the beads in country, some of these assays you can get down to $3 or $4 per child. And then did I respond to all the questions?
Yes, we have 3 minutes. I have put the resources again in the chat now that people can see it. I would like to say that there's so much to learn from this, right? we are learning that the relation between vaccination, even from tetanus, that is, I mean, you only get immunity for tetanus through vaccination. It would be really interesting. For measles, of course, you get immunity, antibodies from disease and from vaccination. Same for rubella in places that you vaccinate against rubella. So I put in the chat one study by Wangfeng Gong. He's now in the Gates Foundation, but he used to be in Hopkins, a PhD student, where there was some triangulation. And I would love to hear in the last 2 minutes, anybody with experience doing triangulation of serological data, and really whether that has led to any assessment of the cold chain, because what occurs to us is either the vaccine is being frozen, say for pentavalent, that it ruins it, or it's being too hot, say for polio. So anybody in the audience, just please unmute yourself and speak. Thank you. Nicole, in the meantime, if you can put your email in the chat for if that's okay with you, for people to contact you with particular questions. I would love to be copied just because I'm super curious about this topic. And
also I see Dale. Dale
yes.
has also been a huge part of many of our sampling strategies. So thank you, Dale, as well. Give you a personal shout out.
Yay. Oh,
and then,
Alex needs to unmute people, so you need to raise your hand if you have something to say. Sorry. Nicole put in the chat here, email. Any last comment? Anything from anyone? I don't see hands. So anyways, I don't see any hands. So thank you so much, everyone, for joining. Send emails with questions. Please do copy me. Again, I'm super curious about this topic, and let us know how we can also showcase work you are doing in these informal sessions. Thank you, everyone, especially Nicole, for having joined from Kinshasa. And I hope you get in contact with Marcelin Nimpa. He's also in this call to solve the mystery of especially Olomami, I would say, with the very high coverage, and then all these outbreaks and some mysterious things there. Thank you, everyone.
Yeah, and we're always open for collaboration. So please, anyone, feel free to reach out. There's definitely so much data and so many questions and things to look at. So thank you again for letting me share this presentation. And I really hope this can lead to some additionally really great discussions and thoughts on how we can improve routine immunization.
Thank you so much. I'll share the resources that I put in the chat, and Anna, thank you for sharing one on NTDs and malarias and VPDs. Yes. But it's super, super relevant.
And Carolina, I shared the PDF presentation with you as well. Feel free to share as well.
Great. I'll share with everyone along with a copy of or a link to the recording and these resources. Thank you, everyone, and happy Thursday for everyone. Thanks. Bye-bye.
Bye.